Okay. Before we get started on the talk, I wanted to quickly provide a bit more context about the work of the Eisenberg Family Depression Center and our focus within the data and design course. You can better understand kind of what we're hoping that you get out of this session today and how else you can connect with us going forward. So the mission of the Eisenberg Family Depression Center is to improve lives and empower communities through bold innovations and interdisciplinary collaborations across research and outreach that advance how we understand, treat, and prevent depressive illnesses. Within that larger mission, the goals of our program, the Data and Design Core, are to reduce barriers to academic research so that investigators can generate impactful, innovative research more efficiently, and to support emerging scholars so that they can build robust long-term research careers in the field of mental health. And the key mechanism we use to work toward that goal is leveraging secondary existing data. So our hope for these sessions is for you to see real-life examples of how investigators have applied these types of data in their own research careers across disciplines, understand the breadth and depth of research accomplishments that can be made using secondary data, and see concrete examples of the benefits of collaboration to advance research goals. So with that, I'm happy to turn it over to Anau to provide a few more introductory comments.
Awesome. Good morning, everyone. What a lovely turnout this morning. Thanks, Megan. My name is Anau Zhang. In addition to the affiliation with the university Megan has shared with you, I am proudly a member of the Eisenberg Family Depression Center. I'm also a participant of the Research Incubator Program, which I had a lot of fun and just also gained a lot of insights in working on using secondary data. So just want to do a quick shout out to the incubator program. So my research program focuses on social determinants of mental health, specifically targeting the adolescent and young adult cancer population. I also view myself as a sort of a different type of translational researcher, if you think about this, right? So what I do, and my team does, is that we hope to translate what we've learned from working with secondary data, those mechanisms such as mediators and moderators and pathways of change that we've identified, or through which those determinants impacting young adult cancer survivors' outcomes. We're hoping really to be able to integrate these determinants and mechanisms into the development and testing of evidence-based mental health interventions for this unique population. So it's the translation from secondary data to intervention development. So to that extent. So it does give me great pleasure to introduce my colleague and collaborator, Dr. Kaiping Wang today. Dr. Wang is a tenured associate professor at the University of Michigan Graduate School of Social Work, but also an affiliate at the did I say Michigan? At the University of Denver. At Graduate School of Social Work and the faculty affiliate at DU's Noble Institute for Healthy Aging. Dr. Wang is currently a principal investigator on two NIH-funded research projects, one by NIDDK, the other by NIA. And he has many other funded research projects by foundations and other mechanisms. Very impressively, Dr. Wang has contributed to nearly 80 peer-reviewed publications, and he's not old, including many. He's the first or lead author for using secondary data set for his program of research. So it is needless to say that Dr. Wang has a wealth of knowledge to share with us today on the use of secondary data for scientific investigation that focuses on mental health research, especially with a sort of a lens through social work and health disparity, which I'm very much looking forward to hear his talk. So without further ado, I present to you Dr. Wang.
Good morning, everyone. Before I start my talk today, I just want to thank all of you for taking time to come to join us and to share this wonderful morning with us today. And also, I'd like to thank Megan, Maria, and Anau for helping me prepare for my trip, and also the slides as well as the presentation. And a little bit of self-disclosure: this is the first time ever I've been invited to present a talk, in-person talk outside the classroom setting. So my imposter syndrome is telling like, why am I here? Like, what do they want from me? And things like that. So since they may already have everything, so and then Megan kindly and graciously shared that, you know, we really want to hear your experience of, you know, how you build this collaboration and continue with these interdisciplinary projects. Well, I can do that storytelling, right? So I'm not going to focus on too much on the data statistics. I will mention a little bit if necessary, partially because you have Meg and Emily there, so always someone to look out for. Here we go. So today I'll focus on leveraging secondary data in mental health and mental health disparity research, mostly for older adults, but I also do research for some other marginalized population as well. For my background, I identify myself as applied gerontologist. So my area, my research aims to promote healthy aging, particularly among minoritized aging populations, particularly identifying factors that influence the wellness of older minoritized population, exploring mechanism by which social determinants affect health and cognitive and mental outcomes. And based on survey data, based on secondary research, develop and testing community engaged interventions to address health disparities for this population. So before we get started, I want to briefly review of like what is secondary data, just to make sure that we're on the same page. So as the name suggests, which I don't like personally, the secondary data makes your research sound like secondary, but we know that a lot of times the work coming from these publicly available data sets are important and they are critical given their large scale national representativeness and things like that. So I personally don't like the name, but it's used anyway, so I just go with that. So so they're data collected by others for a broader or different purpose, but then they are repurposed for answering your own questions of interest. That's the very broad definition. With that, the sources for secondary data can be various. It could be from large-scale surveys. I'm sure most of you are familiar with those large data sets, health and retirement study. It could be from administrative records, such as the CMS data, Medicaid and Medicare. And Emily has shared with me about the resources for working with CMS data. I was very jealous of, you know. And then electronic health records, for example, the PCORNet has a lot of electronic health records for patients' health and mental health outcomes, as well as their demographic information. But I also want to mention that given the broad definition of secondary data, it doesn't have to necessarily be large. We know that those large data tend to have large sample size, but the information might not be something that's specific you want to look at. So so for my research, I also I collaborate with my colleagues and actively reach out to see what kind of project they have worked on before. And all of them have collected small sample size data, but they ask very intensive questions about particular outcome of interest with very established scales. So a part of my current work is on advanced care planning. So I happen to collaborate with a mentor and current colleague from Michigan State University. So he happened to collect data from about between 400 and 500 participants on related to dementia prevention and knowledge of cognitive health and things like that. But they happen to have use advanced care planning, advanced directive as a covariate. And I'm interested in palliative care among immigrant population, Asian Americans, etc. So I was able to, back then there was very limited research on this area among Asian Americans and immigrant population. So I was able to use those kind of data they have collected and publish these articles on factors, social and cultural factors related to advanced care planning and also advanced directive. And that helped me to to display some pilot results and help me to secure some of the external funding that Anil have mentioned earlier. So just want to tell you that the secondary data do not only refer to those large data we already know. So even a small data set your colleague have collected can be repurposed for your own research question if you know the context of the survey, right? So with now we have on the same page of secondary data research really means. Now, what kind of factors help you to develop? Because given the secondary data, we need to figure out there are so many variables available. What do we do with it? So how to come up with a question? Think about whether there are available data that for you to address the questions, and then whether the measures and the data sets are accurate, clear, and reliable and complete for your research needs. And those are very important because they ensure they can help us determine the validity of our findings and also the generalizability of our findings. Also, whether your research question is related to your professional research interests, but also to your personal and community interests. So I will use an example to show you that I published early in my career stage. I worked at a smaller, not in terms of population, but like a research scale, smaller college, where I did a lot of work with food insecurity because that's what my colleagues, the university, as well as the community really care about. I was living in Case County, and 1 of every 7 households are suffering from food insecurity in where I live. So that topic becomes like, it relates to me back then when I was working there, and also relates to the schools and the community as well. So that also determines what kind of question you want to work with, and also potential collaborative opportunities, whether you have people from different perspective and disciplines to share the critical lens with you from various levels, and also whether they're feasible and the scope is appropriate given the timeline, given the methodological and conceptual expertise of your team, whether you can finish it within a certain time frame. So for today's talk, again, thanks to Megan, who have shared with me some the thoughts on what this group of people might be interested in. So I'll be showing 3 different projects with different purposes. The first one we looked at, we focused on describing the prevalence and trend of the problem. The second one, we're going to explore the association between mental health and health outcomes given a specific population. And then the third one, we'll look at the social and environmental protectors of health. So I'll start from the first one. And before that, so the first paper we're going to focus on is on suicidality. I know this is probably a trauma triggering topic for some people. So if you really want to, take a deep breath and really take care of yourself, or simply be absent-minded, feel free to do so. But this is just want to make sure that you ensure your self-care. So this is actually a project where I collaborated with Dr. Lindsay Volheimer, who's also from social work at Michigan. I'm not sure whether she's affiliated with the Center of Depression, but she is. So that's great. So where we describe and examine the trends and the prevalence of non-fatal suicidal behaviors among adults in the U.S. from 2009 and between 2009 and 2017. So really, so back then, this is storytelling. Back then, I already knew Anil very well, so we collaborated on a few papers. And she happens to work with Dr. Bonheimer for a while, and he learned that she's interested in. She knows this large data set, the National Survey of Drug Use and Health data set, and she's interested and have experts in suicidal outcomes. But she needs some support with analyzing trend, because it's very interesting. Over the past few years, what the prevalence of suicidal outcomes and change looks like in the United States. And I happen to have experience working with trend analysis using other types of data for older adults. So that's So and now again, like Bill said, so it's always the hub of all kinds of collaborations. So where we set up a small meeting, we talk about how we could potentially help each other given our common area in mental health disparities and secondary data analysis. So that's when the collaboration started. So I'm going to use a lot of Venn diagrams in this. So referring back to the slides when I talk about research questions. So we have this data set available. The quality is good. A large representative sample. We have over 300,000 people over between 2009 and 2017. And the outcomes are very specific, not just suicidal attempt, but also ideation and plan. So that was the data were overall in very good quality, but also relevance to the current issues, given that it's the suicidal rates in the US have been increasing over the past few years. And in terms of feasibility and scope, so the National Center for Health Statistics have published very clear guidelines about how to do trend analysis. A very long document, and I happen to have done some work before, so I think it was feasible for us within the time frame. And also there were some nuanced questions that we really I was hoping to get answers from, and Lindsay was knows the statistical support at University of Michigan, and they helped us with some minor issues with data cleaning and visualization. The data came from the NSDUH survey administered by SAMHSA. So it was so they use stratified area probability sampling methods to maximize the national representativeness of the results. And also the data were collected annually over the period of time. So for the outcomes, so they assessed suicidal ideation, which is think about trying to kill yourself, suicidal plans, make any plans or not, have you tried to do this, suicidal attempt, and they're all dichotomous outcomes. The focal variable, as we're interested in learning about the trend, so obviously the focal variable of interest is the time, so year, and to avoid reduce or to address potential collinearity, we mean center the year variable. The covariates we included are the demographic factors, as well as the clinical factors, mental health, illness, as well as treatment and substance use status based on these variables. So we started by looking at the unadjusted trend, just to go get an overall picture of what suicidal rates look like. In the past few years, I posted the link to the NCHS guidelines for trend analysis here. So it's a very long document, but the idea is given that we have limited years, we are not able to do more complicated time series analysis. If you happen to know that the ARIMA framework focus on time series methods, and we don't have those data points. So what are we going to do? So this guideline gives you a pretty detailed instruction about how to do trend analysis given limited data points. So the idea is we'll focus on using polynomial regression. So using time and constructed a higher order of the time variable and include cubic, quadratic, and linear term, depending on how many times you have in your data sets. In this case, based on the recommendation, we started with a model with the cubic, quadratic, and linear term. If the cubic is not statistically significant, you remove that and focus on quadratic and linear. The quadratic is not statistically significant, you focus on the linear and things like that. So after analyzing the unadjusted annual trend, we focus on what it's going to look like after we adjust those covariates, so the adjusted trend. And also we looked at how the trends may vary by demographic and clinical characteristics, because we want to know, which subgroup of people have shown more increase than the others, right? So that is done by adding the interaction term between each subgroup indicator and the linear year term based on the above adjusted trend models. So these are the results we have. I think I would just start with so the first paragraph is an unadjusted trend, and you can see that on the right side you see the quadratic and cubic term for suicidal ideation are statistically significant. So there is a little bit of curvilinear relationship over time, but that's not the case for plan and attempt. So you can see that the top one is the ideation, and then plan, and then attempt. So for plan and attempt, you see there is a clear linear relationship there. So it's pretty much increasing every year. For suicidal plan, so after you adjusting for all the covariates, a suicidal plan, the odds of having planned for suicide increased 3% every year, and that's pretty significant. For suicidal plan, for suicidal attempt, the odds on average increased by 4% per year, and that's pretty. And think about over this 9-year changes, how much have increased over the time, right? We also did some heterogeneity of trend to see whether this trend varies by covariates, and for age, we found that this increasing trend was only statistically significant for younger people. So age between 18 and 25, between 26 and 34, but not for the older kind of folks. And for education, we found that the increasing trend was only for those with like middle level of education, so completing high school and some college or associate degree, but not for the less than high school or college and graduate above level. So that could I'm terrified. I'm not an expert in suicide. I'm thinking about why is that case, because probably it's because there's so much uncertainty over the past years for the people who are struggling with their career, their whether they're going up or down. So there's a lot of turbulence there, which causes a lot of anxiety and suicide provoking triggering factor. And we also found that the increasing trend was only statistically significant for female, but not for male. And also the trend was only statistically significant for no mental illness, but not for those with mental illness. So I was thinking about whether there could be like a reduction or lack of preventive care for people who haven't been diagnosed with illness or who are underdiagnosed. So I was thinking about that. But again, Lindsay is the one who should be more adept at telling the story. I'm doing my job here. So for suicidal attempt, we also find the increasing trend varies by mental illness and treatment. So the trend was statistically significant for no mental illness and mental illness, but no treatment, but not for those with treatment. So again, I think if for people who have been connected doctors, providers, they have a protective factor. But again, for those who are underdiagnosed, who don't have treatment, their lack of support may also be increasing, right? Substance dependence, the increasing trend was more pronounced for those with drug dependence than those without drug dependence. So implication not for the research, but for today's group, I think is sometimes we prefer to use longitudinal data to infer causal reference. But when you don't have longitudinal data, you have multiple ways of cross-sectional data. You can still do something about it. Given their national representative nature, you could see over time what the trend looked like. So trend analysis is a useful tool for us to discover emerging and aggravated health and social problems, and also help us to explore which subgroup is at increasing risk of a phenomenon or a problem, which provides a lot of useful information for storytelling, particularly in terms of the historical background information about policy influence. But at the same time, we should always be cautious of making conclusive statements, just giving that we need more complex analysis to do causal inference. So that was my first example. The second example is the one that I collaborated with Dr. John on, looking at the relationship between depressive symptoms and self-rated health among older adults with cancer. So we look at the association between these two constructs and also whether this such association varies by education for older adults living with cancer. So yeah, it looks yeah. So on this slide, you see another Venn diagram. I was trying to find, in terms of the feasibility, identify what each partner can contribute to the project so that to make sure it's feasible. So Dr. Zhang is interested and has expertise in psychosocial oncology, very interested in self-rated health. I'm interested in healthy aging and health disparity and also secondary data analysis. And we both share knowledge of the National Health Interview Survey and social determinants of health, and that's when the collaboration started. So we used the 2019 survey from the National Health Interview Survey, and the data quality has been good. Has large and representative sample size for cancer survivors, which is relatively big compared to other studies, as these are hard to reach populations. So I think the sample size is good. More importantly, when we study cancer, it's always important to control or to address different kinds of cancer. And the data set is over at least 28 types of cancer to control for, which is important for the rigor of results. In terms of relevance, we know that over 70% of the cancer patients are above 50 years old. Almost half of the cancer almost half of the people who die from cancer are above 70 years old. And more importantly, I didn't know that self-rated health, it's a single item, simple measure, but it has been associated with so many clinical outcomes such as psychosocial well-being and psychological well-being, physical well-being, and mortality. So I didn't know how powerful this measure is until I was working with Anil and they shared that with me. So and then it's publicly available cross-section data, so very feasible. So and the data set, so the study used cluster sampling techniques to maximize the representativeness of the results. Originally has over 30,000 people, and we screened over 2,000, a little bit over 2,000 for those who met the criteria, age 65 or above and had cancer. So the outcome is self-rated health variable. Most of you, I believe, are familiar with this. I collapsed very good and excellent into one group just to address potential violation, to address the violation of proportionality of odds assumption after different trials and errors. And then depressive symptoms were measured by the PHQ-8 item, and that's our focal independent variable, and education as our moderator. And we also had demographic information, chronic health information, age of cancer diagnosis, and 28 types of cancer as control variables. So we use ordinal logistic regression with survey ways and multiple imputation by chain equation to address missing values. We started looking at the main effect of depressive symptoms and education on self-rated health after adjusting for covariates. And we want to look at how that association varies by education level, because education, it's an important indicator that could represent how people might cope with depressive symptoms, which influence their health later on. So we then use Wald test to test whether the interaction effects were significant and did some post hoc estimation. So here's very briefly, we found that interaction was statistically significant. Or more specific, as you look at the post hoc estimated adjusted odds ratio, we found that as one's education level goes up, the association between depressive symptoms and self-rated health becomes stronger because the odds ratio is further away from 1, right? So so that indicates that people with higher education, their self-rated health might be more sensitive to their mental health status. So what is the implication for this group? I think, again, this is based on cross-sectional data. So we have limited quality for rigor, but we still, just given that if we have theories to support our research, there could be opportunities there. So researchers might have established a relationship for a population or a broader population, but it doesn't necessarily represent the same for another population, for a specific population. And I think that could potentially lead to a lot of collaboration for people who are working on a specific population. So the third, so that was the second case. And the third case where I really want to highlight is the one I collaborate with Dr. Nicholas Bishop, who was my colleague at Texas State, but now a tenured professor at University of Arizona, where we use health and retirement survey a lot to look at the social determinants of health, of comorbidity, mobility limitations. So this project, we looked at the relationship between food insecurity and mobility limitations, both at the endpoint values as well as changes. And we want to look at whether this association may be moderated by baseline chronic health conditions. So basically whether the number of, so that's guided by the disablement theory for, if you're familiar with the aging theoretical framework. So I want to highlight the context for collaboration. So if you happen to be working as a director or administrator at a research institute or academic unit, your simple action could have a lifelong impact on researchers. In my case, back then when I was at Texas State University, our program is very small in school social work, but we happen to have a very good proactive research building director in our school. So when we immediately after we hired, he shared all of our CVs to all researchers in any other academic units. Just that simple introduction with attachment. That's all, and that leads to a lot of interdisciplinary collaboration within the school, within the university, and that's how I met. Then Nick approached me and said, "Can we have lunch together? I like to talk about my work," and that's how we got to know each other. And I can't emphasize how much that impact, how strong that impact is for me. If you happen to have folks who are underrepresented, scholars, or particularly those who came from who are international scholars, and they often have trouble finding people to collaborate with. I happen to live in San Marcos, Texas, and that's one of the towns where you see very few Asian faces. If I go to a restaurant at one place, the next time I go to the same restaurant, they would just say, "Are you going to order the same thing again?" They'll say that. So I'm just saying, if you happen to have people who are like that, just a simple outreach could mean tremendously to marginalized junior faculties. So just want to tell you that. So Nick, my collaborator, has interest in comorbidity, so more of the clinical outcomes, comorbidity, physical function, nutrition, but also has knowledge in health and retirement study and longitudinal data. Well, I focus on conceptualize food security as a social determinant of health for older adults. I'm interested I've had experience using longitudinal survey, but I have never had a chance to use our HRS. I feel if you're a gerontologist, you have to use this. So that was like a motivational kind of moment for me to start working on the data set, given our interest, mutual interest in secondary data analysis and healthy aging. So we use the health and retirement. So data available for addressing our research questions. So we use the HRS data as well as a healthcare and nutrition study from the HRS supplement. So again, it was nationally representative on a certain level. You know that it has more participants who are non-Hispanic, white, Hispanic, or Black, but not for other groups. So I usually say representative on a certain level, yeah. And then was longitudinal data were collected every other year. It's, as I mentioned earlier, it's just feels so relevant to not only to our professional interests, but also to the community as well. Just given, I was also a board member for one of the local communities, and it was just exciting and motivational for me to work on projects related to food security and their implications on health, right? So and there was of course interdisciplinary opportunities. So Nick was interested in nutrition, aging, but also a demographer. I learned so much from him in terms of building quantitative research capacities, because he's also a demographer as well. And also he works before moving back to academia, he works in the state government, working with researching on public surveillance system, and has a lot of experience using data. So that helped me a lot. And the HRS and the supplemental modules are publicly available. So the timeline was also feasible for us. So we used the 2012 and 2014 health and retirement study, and the 2013 health care and nutrition study. Unfortunately, this study was only collected at one point for the supplemental part, but it's still enough for us to address our question. So the sample size for the supplement who are eligible for our study is a little bit above 8,000. And we used, so they happen to have the USDA standardized scale for measuring food security. So if you score between 0 and 1, you're food secure. If you score above 1 to 6, you're being food insecure. So that was their official definition there. And then mobility limitations, our outcome. We use a count of 11 established indicators, and our moderator is the chronic health conditions. So that includes things like hypertension, cancer, diabetes, etc. We also control for demographic characteristics, as well as health behaviors and characteristics. So we started with analyzing the association between food security and mobility limitation in terms of the instantaneous effect, just by regressing mobility limitation in 2014 on food insecurity, chronic conditions, and covariates as some sort of cross-sectional approach, even though food insecurity is collected the year before that. And we found that compared to those people who are food secure, the food insecure people has 20% more higher incident rate ratios to have an additional mobility limitation, and that's pretty high. And after that, we want to see whether food insecurity may also contribute to the change in mobility limitations there. So one way to do that is, in addition to the cross-sectional model that we did before, we also added the baseline mobility limitation after log transformation. And we found out that association between food insecurity and changes in mobility limitation still remains statistically significant. So compared to those who are food secure, those who are food insecure has 6% higher incidence rate ratio in terms of incidence rate in terms of mobility, having additional mobility limitation. So I won't bore you with lots of stats on the interaction effect, but I think sometimes the figure tells you the story. So the idea is, as you can see from the figure, for both the instantaneous effect and the changes, the disparities in mobility limitation between the food secure and food insecure group are more significant, are more pronounced for people who have lower levels of chronic health conditions at the beginning. So what does that tell us? First of all, we confirm that compared to older adults who are food secure, food insecurity is associated with higher numbers of mobility limitations, but also more rapid increases in mobility limitations. And the association between of the constructs above are more pronounced for people who have fewer chronic conditions at baseline. So what does that tell us? I think part of the story is that in terms of a nutrition and food assistance program, we really have to do this kind of intervention a little bit earlier before people develop more chronic conditions to maximize the effectiveness of those programs. So those are for that specific project. I'm also excited to tell you that after we finished one paper, we have worked on the HRS more often and had even more ideas about different kind of projects. So these are just 3 of the at least 5 papers we have published based on the HRS project. So I think just like, again, it all started with one email reach out from a director from the school. So it has a very great impact on my work. So I want to at the end make some I guess personal reflections on secondary research, and interdisciplinary collaboration. So there are benefits and challenges of working with existing data. I'm trying to avoid using secondary because we know that the benefits are where we have access to large-scale data sets for diverse insights. For example, we can work on different outcomes depending on our interests and also relate to the interests of the community. But also it's a cost effectiveness and time saving benefits also attract us all to work on secondary data. I also do primary data research, and I can share for hours on how much efforts I put on that. The endeavor takes forever, and the challenges are, we always want to make compromises, or whether the measures in the data sets exactly measure what we want. And also, we need to be, particularly as a social worker, we need to be more considerate when we interpret the results. So, especially when we're trying to repurpose the sensitive data, how can we produce results and interpret the results in a way that can empower people and communities who are underrepresented instead of adding additional stigma? And that's important. In terms of interdisciplinary research, I think one key is to make sure that we are open to scholars and perspectives from disciplines, because without meeting Nick, without meeting a demographer, I wouldn't be able to handle more like complicated data using biomarkers and stuff like that later on. So that kind of I think openness to new perspectives will always enhance opportunities for collaboration and innovation in innovative insights in working with existing data, and also help us to enable like challenging investigation. So part of my interest is to look at the intersection between mental, emotional, and also cognitive health being. And to answer those questions, I don't think any discipline would be able to achieve that goal. We really need a team of experts from different areas to achieve that. But more importantly, I think as a social worker, a lot of times we're immersed by media telling you a certain lifestyle is related to a better health outcome, better memory and stuff. But be mindful that those results a lot of times come from a study or a data set where people who are non-Hispanic, white, cisgender, and heterosexual people are more likely to be represented in that data set compared to other marginalized background. So we really need to, as a social worker, I always pay attention to what the results are like for underrepresented populations, and investigate a potential mechanism that could explain the disparities and determinants of mental health and health among minoritized groups. And more importantly, I think as a social worker for myself, I want to make sure that my results resonate or can help community partners to understand the story. So back to the example I mentioned about advanced care planning, back then, I don't think there was a single study that talks about this issue for Asian Americans, particularly for Chinese Americans, partially because advanced care planning was not even heard of in like other countries who moved here. So and that's when we learned that the utilization of advanced directive is not even half as the general US population. It's much lower than non-Hispanic white, blacks, and Hispanic. And that's when I started the topic. And I happened to partner with an agency that work specifically promotes palliative care among Asian Americans. And they were excited but not surprised to see the result. And then when I presented the result to them, they feel resonated and they share me, when they provide assistance to regarding like legal system with advanced care planning, what are some of the challenges they have ever faced before? So they help me to tell the story in a better way, and also that helps me to help them refine their procedures of advanced care planning promotion and assistance with the advanced directives. And I believe my time is up. And I just want to thank you for your time here. And yeah, I appreciate the opportunity to share my experience. Yeah, thank you.
Thank you so much. That was excellent. I can't believe that was the first time you did that. Not a lot of time. We have about 10 minutes for questions.
Thank you, Kathy. This is I really appreciated hearing the story about getting lunch with this person and sort of the way that collaboration, was intentional, but also sort of, had its organic, if you will, elements. I mean, could you maybe talk a little bit more about how the fact that the sort of, I guess, how the relative ease of entry using that you had this data set that you wanted to use, this person had experience with, just sort of how, especially as a first stage of a collaboration, that was particularly important, or again, maybe, you don't have the counterfactual where you are starting a giant data collection with this person, but I can see sort of, I think when we think about secondary data, I think sometimes we miss the fact that you have to walk before you run sort of thing, and especially with a new collaboration, there's a lot of things that kind of go wrong with data collection or, the large scale efforts like that. And so maybe could you sort of just speak a little bit about how the fact that you didn't have to jump through those hoops in order to generate a product that was mutually beneficial, that is, a publication that was going to help advance both of your careers and establish a working relationship, how that was advantageous at that stage.
Yeah, I thank you for your question, Bree. I just I think that's a very good question, and I would say the products or the success or the procedures really depends on a lot of factors. Some of the factors that you can control for example, the things like the institutional level support was very helpful, and also I think for myself, I'm always willing to. I mean, I guess when I was first year for my junior scholar, like I didn't know. I think part of the sense of insecurity helps me to kind of try to open to any kind of collaboration that I work with. Of course, you encounter some people who are productive and have a clear goal of what they do, and you're lucky to have that kind of person. But I also, in my institution, I also have to know some people who just want you to do some work without giving any like clear picture of what they want to do in the long term. So I feel like as a junior faculty, if I went back and redo it again, first of all, I really want, before any kind of collaboration, even if you're working on a different topic different from mine, I would really want to make sure that like what you're doing in the long run, how this result will benefit your own professional interests as well as the community that you care about, because that kind of collaboration will carry forward in the longer run. And there are, of course, things that you don't control for, like what are some of the things that you're not interested in, you're not sure aware of. And I, as a senior faculty, I always like to give people a first try before anything happens, and I always want to make sure that I respect their work, and also if it turns out not to be clear as I expected. I always like to maintain some boundary. I mean, I'm happy to provide like consultational work, like if it is quick and that can always help people, but also make sure you set the time boundary for certain levels as a junior faculty. And in addition to that, I think you also mentioned like the learning curve from less complicated data set to something more complicated. I think as when people move forward with different career levels, it is important to build networks. I don't think I'll be able to handle like the more complicated data set like the CMS data, which I'm currently looking for, but I'm not like, but just looking at the data, I don't think I'll be able to do that myself. So I think that again requires really the courage for the individual to really meet and talk to people and to establish long-term trajectory, what they want to do together, and also be open-minded. But at the same time, what institutions can help with junior faculty in terms of accessing to not just the data set, but also the consultation with the data. That could be instrumental to faculty who are learning more data set. And I don't consider myself as like the advanced expert. I appreciate the compliment. I don't think I consider myself as that level yet, but I do think that just University of Michigan, from what I heard yesterday, you have a lot of resources. I just take advantage of these resources could be very helpful as well. So I would say a lot of factors from like individual, like departmental, but also institutional, like how you can utilize those services to help you navigate the process. Yeah, not sure if that answered your question. I could think of more, but again, this is my first time talking, so I'm pretty sure later a new point will come to me. I wish I mentioned that. Yeah, I would say that.
I have a quick comment and a question. So the quick comment is the health retirement study. One of the things you talked about, secondary data analysis, one of the amazing things is that a lot of the data, while anonymous, are very quickly accessible. And one of my undergrad students, before she even came to me at my last year, she was like a sophomore, together with another undergrad, did a study and published on the health and retirement study because all the data were available. She ended up, I recommended to her to have someone from the HRS involved, but really the study was done by 2 undergrads with publicly available data. My question is, it's amazing that in this whole context, my favorite word has never been mentioned. I'm a geneticist, and while you were talking, you were mentioning that this self-assessment of health or self-rating of health is so much associated with anything. So according to the internet, the way I just figured out, I don't know whether this is true. It's between 30 and 60% genetically influenced, and it's mostly personality. And that was sort of my feeling earlier on. Could it be that a lot of these very strong associations may simply be a person's outlook on life? Like there are a lot of discussions now in politics about people feeling they're doing worse, whereas objectively they're actually doing as well or better than they were feeling, than they were a while back. And could it be that a lot of this personality factor of being sort of an optimist versus a pessimist may be part of this association? And have you tried to figure that out as the correlation is probably there, but whether it's a causation, I don't know.
Yeah. What's your name? Sorry. Margaret. Thank you. I appreciate the question. I think you mentioned the concept of personality. I've always think about like having gone through some like health and like mental health challenges, as well as working with people who have as a social work intern with people at a homeless agency where I've witnessed people who have different kind of life challenges. I would say like personality exposure itself is complicated. And you can there's research that suggests I kept thinking about the problem, but I didn't find a data set that could really fully capture the personality aspect of research. But I think personality itself is a complex construct. Is not just related to it's related to one's genetic effect, but also related to how the social environment shape one's personality over the long term. I think in the long run, first of all, we need to parse out, what does it mean by personality, and what aspect of the personality we're really interested in, and also how whether there's any social and environmental factors that could moderate the influence of personality on one's health behaviors, and also access to health services, and as well as outcome. So I think that's definitely an interesting question to look at, and starting with some pilot study. But please feel free to let me know if there's any data set that captures both the genes and personalities as well as outcomes from the clinical biomarkers. I think it would be interesting to look at in the long run. But at this point, I kept thinking about it just for myself. I tend to be a very hypochondriac about what I'm experiencing today. I don't know whether that's related to my family history or anything. I kept thinking about that, and that sometimes I relate to. That could be a research question that I want to look at, but I just don't have the data at this point to look at. But definitely worth investigating in the future. Yeah.
We have time for
in your showcase one,
yeah,
you talk about mental illness. Can you tell me what that actually entails? Does it entail people living with diversity, or schizophrenia, depression?
Sure. It's been a couple of years since I worked on this study, but let me see. So basically, the mental illness was based on a composite variable that includes schizophrenia, depression, depressive disorder, and maybe other types. And partially because we already have a lot of variables that are related to mental health. I think just for maintaining the statistical power. We also did some analysis by breaking that into different groups. We didn't find statistically significant a difference in terms of a trends for those subgroups overall, and that's why we collapsed the self-reported diagnosis of mental health into one category, whether you have those mental illnesses and whether you have been treated for that condition altogether. Because for each, I forgot how many types of mental illness there were in the data set, but for each of them, you have to add two variables, whether you've been diagnosed with this, whether you've been received treatment for this condition. So it would be a lot of variables to include, and that's why we analyze the data in this way. Yeah, but it was based on self-reported diagnosis of a doctor diagnosis of a certain condition. I forgot how many times exactly, but it was later condensed into this one variable. Yeah.
Well, thank you so much. We are at time. So we would love if you would stay for a networking reception for the next hour. I think one of the themes of today's talk was the importance of collaboration. So when you registered for the talk, we asked you to name one or two of your research interests, and those are listed on your name tag. So maybe use that as a little conversation starter to talk to someone that you haven't met before. So the reception will be open for the next hour, and I think Dr. Wong and Dr. Zhang will be still here if you have additional questions or conversation. But thank you so much for joining, and we hope you'll stay for some snacks. And thank you for holding up on the food until now, but you can eat now. Thank you.